Good afternoon, everyone. Thank you for being here. I'm going to go ahead and introduce our speaker, Dr. Janet McGill. Dr. McGill is Professor of Medicine in the Division of Endocrinology, Metabolism, and Lipid Research at Washington University School of Medicine and attending physician at Barnes Jewish Hospital in St. Louis. In addition to seeing patients with all forms of diabetes for over 30 years, Dr. McGill has been an active clinical investigator of the pathogenesis and treatment of type 1 and type 2 diabetes and diabetes complications. Dr. McGill led the Washington University site for the Type 1 Diabetes Exchange Clinic Registry and was the senior author on a paper describing polyautoimmunity in the registry of 25,000 persons of all ages with type 1 diabetes. She is currently a sub-investigator on the Radiant study, which hopes to discover genetic causes of diabetes with atypical features. Dr. McGill has served on steering committees and data safety and monitoring boards for long-term outcome studies, both NIH and industry sponsored, and leads the data safety committees locally. Dr. McGill has published over 200 peer-reviewed articles, numerous commentaries and editorials, 25 chapters, and she has edited 4 books. She has served on the editorial boards of several journals and has lectured nationally and internationally on diabetes and related topics. She served on the board of directors and has received the Distinguished Clinician Award, the Alumni Achievement Award, and the Endocrine Fellows Teaching Award from her peers at Washington University. She will receive the Outstanding Physician Clinician Award from the ADA in June. She is obviously very qualified, and I'm out of breath just reading that bio. So without further ado, I'm going to turn things over to Dr. McGill. Please try to hold your questions until the end of her presentation. If you are thinking of a question and want to type it in the chat so you don't forget, feel free to do that. But we will go back to the questions once Dr. McGill has finished her discussion. Thank you everyone for being here, and thank you, Dr. McGill. We so appreciate having you.
Well, thanks everyone. I'm going to share my screen. So, okay. All right. So I'm going to talk to you about my favorite topic today, which is diabetes. I've spent most of my life studying or managing diabetes. I've learned a lot. We're in a different place today than we were some years ago. So I'll try to convey that. And there will be time for questions, so please keep your questions. We always put up a disclosure slide to show any conflicts. I do have some research funding. I do some consulting. I do a variety of things. That's what it looks like. We have some goals of the presentation, but mostly it's to develop an understanding and to develop this sense that diabetes is a gigantic problem. It's a problem in this country, it's a problem worldwide. This is prevalence data. How many people with diabetes per number in the population, and we see clustering down here in the southeast. We also see it scattered. These places, some of them are Indian reservations, lots of diabetes on Indian reservations. But what's really sort of daunting is to know that by for people born in the year 2000, their lifetime risk of diabetes is really very high. So for a non-Hispanic white woman, which is what I am. I wasn't born in 2000. I was born before that. If I were born in 2000, my lifetime risk would be 30%. For a Hispanic woman, it's up over 50% lifetime risk. So our risk of diabetes is going up and not down for many, many reasons. It's going to affect our children and our grandchildren even more than it affects us. And it's something we need to be concerned about. Okay. Well, diabetes is painfully easy to diagnose. It's not like hidden cancer or even, many, many other conditions. It's actually, the diagnosis just sort of jumps out at you when you test a blood glucose. There are levels that make the diagnosis. FPG is fasting plasma glucose greater than 126. Or if your blood sugar is greater than 200, you have diabetes. What's normal? So normal fasting glucose is less than 100. And now you see a gap between 100 and 126. And in that gap, we call it at risk or impaired fasting glucose. It's kind of a risk state, but diabetes actually starts at 126. Or if you're doing a glucose tolerance test at 2 hours greater than 200, or if your hemoglobin A1C is greater than 6.5. Again, we see this gap between 5.8 and 6.5. So here in the middle, we sometimes call it prediabetes. If you're above 100, less than 126, you fall into a category of prediabetes, impaired fasting glucose. There are a number of names for that. How is diabetes classified? Well, there are two big groups. Type 1 diabetes, formerly called juvenile onset, has also been called insulin-dependent diabetes. It's an immune-mediated attack on a specific cell, the cell that makes insulin. And if we can't find the immune markers, we call it idiopathic, which means we can't identify it. Or type 2 diabetes, which is really quite a complex disorder of insulin resistance. Insulin doesn't work well. Or some or relative insulin deficiency. It's a very heterogeneous disorder. So people look very different who have type 2 diabetes. And then there are other types of diabetes, like gestational diabetes or diabetes related to steroids or some genetic defects or pancreatic surgery or pancreatic disease. Are these other types or type 3 diabetes? So I'm going to start by talking about type 1, and I realize this group is probably more interested in type 2. But just as a comparison, there's autoimmune destruction of beta cells of the pancreas. Beta cells comprise 1% of the pancreatic tissue. We have markers that are these antibodies. The rate of beta cell destruction varies. There are some genetic predispositions. There are also some environmental factors. There is a lot of variation across populations and regions. The highest prevalence of type 1 diabetes is in Scandinavia. So the blonder the skin and hair, or lighter the skin and hair, the higher the risk, relative risk of type 1 diabetes. The darker the skin or hair, the higher the risk of type 2 diabetes. And there is overlap. It's not all one or the other. And people with type 1 have increased prevalence of other autoimmune problems. This, without getting too specific, this is the islet where these beta cells reside. These cells are pink in the top left. They become damaged progressively. The blue are lymphocytes. And by the time the process is over, there are no light pink cells, no beta cells left. These are other cells. And it's all replaced by lymphocytes. So these islets, the beta cells are completely destroyed, and it happens very quickly in some patients, and they just stop making insulin. The time course for the development of type 1 diabetes starts with a genetic predisposition. There might be a viral or other precipitating event. Insulin release continues, but declines until it no longer does. In children, it happens very rapidly. They have symptoms for a few weeks or a month or so, and then they're in the hospital. In adults, can take years. So the autoimmune disease is very different in children and adults, and it's kind of rather different from one patient to another. There is a familial risk. In siblings, it's 5 to 10%. Monozygotic twins, kind of 10 to 70, but it depends on a variety of factors. This is the only disease where the risk is higher for children whose fathers have type 1 than whose mothers have type 1. Very kind of curious. Okay, there's a disorder called latent autoimmune diabetes in adults, or LADA. So what is LADA? LADA is slow walking type 1. Takes a long time, but it eventually ends up as a type 1. The clinical presentation is variable. It happens in adults. Less dramatic onset than in children. These folks are often diagnosed with type 2 diabetes, and later we change the diagnosis to either LADA or type 1. Insulin is required sooner than in classical type 2, several months to a few years, but sooner than you'd expect. They also have antibodies, have low C-peptide, is the insulin that you secrete from your pancreas. Less likely to be overweight, but they can be overweight, and other autoimmune diseases. So insulin replacement is an absolute necessity in type 1 diabetes. They don't make insulin. You have to have insulin to live. If their insulin is interrupted, they don't take it for 48 hours, they'll be dead. Very simple. They don't take it for 24 hours, they'll be in ICU. In about 8 hours, they're pretty sick. They have a very short time window when they cannot have insulin on board. So the price of insulin and availability of insulin is absolutely critical for these patients. I mean, they cannot live without it. It's important to do physiologic replacement of insulin to avoid high glucoses at one time in the day and low glucoses at another time, hyper or hypoglycemia. The insulin that you go to a lot of trouble to give to yourself with an injection is not the same as your body's insulin. It has kind of a broader peak. It's not secreted, every minute. Onset's delayed. It's not pulsatile. Level cannot increase or decrease once it's administered. And the lifestyle adaptations are because insulin is not physiologic. And because it won't increase when you decide to have a Coca-Cola, your blood sugar will go up if you've already taken your insulin. So the lifestyle adaptations have to do with the fact that we cannot replicate your body's ability to make insulin, no matter how we give it in whatever form. Okay, if your blood sugars are too high for too long, can cause some very serious long-term complications. And if your blood sugar is too low from too much insulin, you can lose consciousness, have a seizure, accidents, and death. And it's a very, very, very much a tightrope that patients with type 1 diabetes walk. So this doesn't even really depict physiologic insulin secretion because it's very pulsatile. They're there are 100 different pulses in each of these red bars. Glucose stays within a pretty tight range, goes up a little bit, comes right down. These are the beta cells here, lots of different influences, both vascular, neural. The biggest influence that causes insulin release is glucose. So when we give insulin back to people, we try to do it in a close to physiologic fashion. So we give this long-acting insulin we call basal insulin, and then we give insulin before each meal or snack or when they eat or if they're high. And as you can see already, we're talking about 4 injections of insulin per day, and often it's more than that. And then there's the monitoring. How do we monitor blood glucose? Well, the new thing are these sensors. This is the sensor that feeds into a transmitter. The transmitter sends a signal. And instead of seeing these finger stick glucoses, which are like a snapshot, you can do a finger stick and you get these 2 numbers, everything looks great, but you miss this big high peak. Now, this is pretty reasonable. You miss another peak, and now you miss a low blood sugar. So a lot is going on during the day that these periodic finger stick glucoses did not catch. So this is one example of a continuous glucose monitor that actually talks to this insulin pump. It can drive the basal rate in the pump, still requires some interaction. This is a continuous glucose monitor where the transmitter transmits to a cell phone. Cell phone goes to mom's cell phone, so mom can keep track of the kid. I have adult children keeping track of older adults with these systems because one of the problems is you might not feel a high blood sugar and you might not feel a low blood sugar as well as you should. So let's look at so if this is the target range in between these bars, having your blood glucose between 70 and 180, and I told you normal is about 100. What's going on with this patient? Well, she's 20 something and she doesn't take her insulin. She takes enough of it to stay out of trouble, but runs really high and it's going to be very damaging in the future. And these are averages, 2-week averages. For every 15-minute time period, you get a 2-week average. That's what you're looking at here. So this is a very typical charting, pretty good overnight. But once you start eating, it's hard to guesstimate insulin doses. Sometimes you're in the gray, which is in range, sometimes too high. It's just, picking that perfect dose is a little tricky, but overall the average is pretty darn good. And this is a patient of mine who's a retired engineer, a woman who's a retired engineer, and she's got it nailed. So she gets it done really, really well. She also has had some bad lows, I will add, but very few patients can do this with type 1 diabetes. Okay, we're going to move on and talk about type 2 diabetes. Let's talk about the age of onset of type 2. So we've diagnosed type 2 diabetes in children. There's a definite uptick in young adults. The bulk of type 2 diabetes is diagnosed between 40 and 65. And then it can be diagnosed at any age as you get older also. So it's across the spectrum with sort of the biggest, greatest number being diagnosed kind of in middle adulthood. So what causes type 2 diabetes? Well, type 2 diabetes, we call it insulin resistance, and I'll tell you what that is. The liver is acting up in type 2 diabetes, and the pancreas doesn't secrete insulin very well. So what's insulin resistance? It's an impaired biologic response to insulin. It occurs in several different tissues. In the case of the liver, there is additional or increased glucose output. The liver makes glucose. It's what supports you when you're not eating, is the liver. But when it gets wild and crazy, you get diabetes. So too much glucose output from the liver, reduced uptake of glucose in skeletal muscle, and insulin acts to suppress, keep the fat in the fat tissue. When it's inadequate or where there's insulin resistance, there's a little too much turnover of fat tissue, and we see increased fatty acids in the blood. So the result is hyperglycemia, is high blood glucose, and high circulating fatty acids. So this insulin resistance problem precedes the diagnosis of type 2 diabetes in the majority of patients. It's fairly toxic to beta cells. So beta cells sort of die off, and then there's not adequate insulin output to account for these defects. And you see this here. Look at the pink. So in the pink, if you get this is a glucose tolerance test. You do a glucose tolerance test, you see a little rise in glucose. These are actually millimoles, not milligrams per deciliter. You see a little rise, and then it comes right back to normal. Don't feel anything, you don't notice anything. But what did insulin do? Insulin had a big spike, little rise in glucose, because this big spike of insulin took care of it. And then even before the glucose is all the way down, the insulin is tapering off. And this is a normal response. IGT is impaired glucose tolerance. Blood sugar goes up a little bit higher, not all the way to diabetes, but it's higher. The insulin secretion is delayed. We don't get that early spike. And because of insulin resistance, it stays up longer. So blood sugar is higher and there's more insulin around. When you finally get type 2 diabetes, blood sugars are definitely higher. Insulin is delayed and inadequate. And that's what it looks like on a glucose tolerance test. One of the things that my patients always struggle with, and I don't blame them, is the progression of diabetes. So diabetes progresses. You're diagnosed, you take one pill, it's pretty cheap, and then all of a sudden your A1C goes up. And you know what I do? And the patients, oh, well, yeah, I will put in even more restrictions. I will be better about something or other. And it's hard to understand that there's this phenomenon of beta cell failure causing blood sugars to go up no matter what you do. So there's progression of type 2 diabetes, just like there's progressive loss of insulin in type 1 diabetes. And sometimes our type 2 patients look a little bit like type 1 after they've had it for a while. They really are very, very insulin deficient. Okay, this is kind of an interesting picture. This is a cross-section CT scan of a normal person and somebody with type 2 diabetes. The kicker here is these two people weigh the same. Their weights are the same. This person, look, has a little more musculature in the back. This is musculature around the abdomen, and the white is fat. This person has sort of crummy musculature, a lot of fat in the abdomen. This person has diabetes and this one does not, and they weigh the same. So having visceral, meaning fat inside your belly versus attached to your hips and legs and arms, inside your belly is more toxic. Your insulin sensitivity, that's the flip of insulin resistance, goes down the more fat you have in your belly. And it's true of heavier people and it's true of thinner people. So we have people who are relative, their overall weight's not that great, but you've all seen them. They have very skinny extremities and carry a little bit of pouch in the middle. It's not uncommon, and they are at risk for diabetes, even though their overall weight is not that great. However, subcutaneous adipose tissue, there's not much relationship with the amount of fat you have and glucose disposal or insulin resistance. Okay, let's talk about other concepts about subtypes of type 2 diabetes. I mentioned that we think we know diabetes because we know, this heavy person that has type 2 and this, thinner person who got type 1 when they were a child, or somebody's child has type 1. You think you know it, but it's really, there are lots of people who look different who have diabetes. So this group in Sweden decided to try to cluster it to understand it better. This is a fairly recent paper. So they took this big group of people with type 2 diabetes, they pitched out all the secondary, the genetic types, and they have this small group of type 1, and then they did some testing and came up with these subgroups, and I'll show you what they look like. So the severe autoimmune diabetes would be what I told you was LADA or a variation of LADA. It's about 6%. Then there's severe insulin deficient diabetes. Looks a lot like type 1. It's not quite type 1. I'm not sure they ruled out pancreatic diabetes. If you have pancreatitis or other problems with your pancreas, you'll look like this. Then there's severe insulin resistant diabetes. There's an increased risk for fatty liver, increased risk of kidney disease. This is a very tough type of diabetes to treat. It's the hardest type to treat. Mild obesity related diabetes. So people are overweight, but their diabetes is fairly mild. And then we have mild age-related diabetes, late onset, and there are no extreme features in this type of diabetes. So we haven't figured out the genetics of these different types of diabetes, but everybody's working on it. What causes this very insulin-resistant type versus these other types? Unclear. Okay, I always get questions about prediabetes. Prediabetes is that area between normal and diabetes in terms of blood glucose. So it's a fasting glucose of 100 to 125. Or if you're doing a glucose tolerance test, it's 140 to 199. You may be getting an A1C periodically from your doctor. So 5.8 to 6.4 is officially prediabetes. If you've had gestational diabetes, you probably fall in this category. What happens to people with prediabetes? Well, 12% per year develop diabetes. Okay, so there's progression. There was a diabetes prevention program where patients got general advice and didn't, otherwise just had follow-up. And this is this 11, 12% progression per year. People were treated with metformin as pre-diabetic while they have prediabetes, and the rate of progression was reduced by 31%. However, people that were really, hammered to adopt lifestyle changes, predominantly exercise, but also dietary restrictions, lost 4% body weight. It's not huge, but it was enough, reduced the risk of progression by 58%. So lifestyle is really the answer to prediabetes. If I'm now jumping back to if we're going to treat diabetes, we do have targets. The targets differ a little bit by which association we're talking about. This is normal is really less than 100. The ADA is 100 to 130 is where the before meal should be. Bedtime 110 to 150. A1C less than 7. The ACE goal likes it a little tighter, less than 6.5. Okay, so what do we do to treat diabetes? We start with diet and exercise, but really only if the diabetes is very mild. If you come into the office with an A1C that's very high, your blood sugar's in the 200s, we're not going to spend weeks and months on diet and exercise. We're going to start treatment. Monotherapy with one or another agent, then we combine them, and then the last thing we go to is insulin. However, if you're in the hospital with blood sugars of 800, we're going to do this backward. We're going to start insulin first and then see what else we might be doing along the way. So if your blood sugar is shockingly high, we just start with insulin. So you can see this takes time. It takes time to add these agents to get it right. During that time, people often, glycemic means glucose targets are not met. So they may be running too high. Monotherapy, single drug, may not be effective over the long term. A stepwise, wait 6 months or a year, 6 months or a year, perpetuates hyperglycemia. And then just high blood sugars interfere with the treatment response. You've got to get the blood sugars down to give the beta cells a chance to operate. These are the different kinds of therapies. They're all quite different. They come as pills and then they come as injectables. Insulin is the best known injectable, but there are this other group that we now tend to give once a week as injectables. These two groups, the SGLT2 inhibitors and the GLP-1 receptor agonists, have been shown to reduce cardiovascular and kidney adverse events. So our tendency is to use these when we can. What's the effectiveness? So an A1C, 1% A1C is about 33 milligram per deciliter in blood sugar. So if you're trying to get to, if your blood sugar fasting is 155 and you want to get it to 120, diet and exercise or a single agent will do that. Some are a little more powerful than others. If we use a combination of agents, we can get the A1C down from 9 to below 7. And then if we really need to get it down a lot, your A1C is 9, 10, 11, then we may need to go to insulin and we may need to start with insulin. So we can't take 3, 4, 5 years working our way through all of this when somebody needs insulin. So the advantages to insulin: controls patients. There are a lot of different preparations, lots of ways to give it. But of course, it causes low blood sugars, weight gain, requires injections, requires a lot of monitoring, it's a lot of trouble. So the other problem we have with diabetes treatment is the cost. So diet plus an inexpensive drug can be $4 a month. And it may not be necessary to really stick your finger or do very much because it's, pretty well controlled. Things are pretty good. So it can either be a very inexpensive, cheap disorder, or it can be very complicated and very expensive. May require more than one oral or non-insulin injectable agent, may require insulin. I have many, many patients on insulin pumps, may require frequent monitoring or use of a continuous glucose monitor, and the cost can easily exceed $2,000 per month, easily. breaking the bank. We'd like to have patients get to an A1C less than 7%. What percent of our patients get there? Well, only about 45%. So over half of our patients have blood sugars that are too high, and too high persistently. And I mentioned a little bit ago about the fact that diabetes tends to be progressive. So you start with environmental factors, nutritional factors, inactivity, add in some genetic factors of insulin resistance. We diagnose diabetes, but if there's ongoing hyperglycemia, we begin to see complications that lead to disability. We think we can correct this if we can reestablish normal glucose levels, which is challenging, very challenging to do that. So our target, what we'd like to do is establish normal glucose levels, but on an individual, one individual to another, everybody requires something different. The cost gets out of hand. Not everything is approved in all groups. I mean, it gets complicated. Consequently, we're not quite where we need to be. And I'm going to stop there so I can take some questions. I'll keep the share on because I do have other pictures available if there are questions about things. So, does anyone have any questions? You want to unmute? I see a number of you are.
So you can unmute, you can virtually raise your hand or literally raise your hand in front of the camera, and I can let Dr. McGill know that you have a question.
Okay, I see 2 questions in the chat.
Okay.
Okay, if you have type 2 diabetes and you've been prescribed metformin, does it have to be a lifelong prescription or can you get off the pills? Well, a couple of things. One is we don't get younger. Those beta cells that we may have lost just by getting older don't come back. I had patients come off of lots of different things. Probably the most dramatic are the ones that have bariatric surgery and have 100 pounds to lose and lose 100 pounds. Most people struggle to lose 10 pounds. So the answer is not no, but the answer is probably typically people do not. Typically there's a need to add additional therapy instead of take therapy away. Now, a couple of other caveats. If your favorite beverage is Coca-Cola and you realize that you need to stop drinking Coca-Cola or sweet tea in some cases, makes a big difference. So there are some things people do that make a big difference. But what if your diet's already fairly healthy? You know, your diet's already, you know, pretty good, 2 to 3 meals a day, quite balanced. You're not drinking a lot of sugar. It's already pretty good. Maybe it'd be possible to increase exercise. All these things become more and more difficult as we get older and older. You know, you can do some walking, there's always room for improvement, but there are also more challenges. So by and large, most people go the other direction and need more therapy instead of coming off But I do meet people who have really terrible diets or really egregious habits that when they get fixed, it makes a big difference. It's a little more common in younger people than older folks. Okay, what are the diet and lifestyle changes you recommend in the pre-diabetes stage? So, if you're overweight, getting some of those pounds off, which means just reduction of everything. Probably a little bit more reduction in carbohydrates and really being very careful to not drink calories. And then what the DPP did, they gave people walking shoes and really were quite adamant about spending 150 minutes a week exercising, meaning generally walking, it could be other things. And the weight loss in the study was 4%. So it wasn't huge. But if you weigh 200 pounds, it'd be an 8 to 10 pound weight loss. It made a big difference, big difference. You know, we're all really designed to be a little thinner than I am, certainly. Okay. Can statins trigger type 2 diabetes? Oh, this is a very sophisticated crowd. This is a very good question, and there are lots of controversy, but there's some controversy, but actually big observational studies do show movement, usually from kind of a pre-diabetes range to diabetes with statins. So the answer is not no. The answer is maybe. You don't normally go from a fasting glucose of 90 to a fasting glucose of 130, but you might go from 118 to 126. So the movement was to sort of nudge people in the wrong direction. And would I recommend against taking a statin for that reason? Absolutely not. Every single study shows that statins lower your risk of heart attacks and strokes. And but I do recommend that everyone, people who don't have diabetes, you know, in older ages, it's 20% over age 65. Goes up with age. So all these folks who've lived with it while they're younger, and then more and more people get diabetes. So it does require active surveillance. You know, none of us are special. We're not that special. You know, we can have, if you live long enough, you'll get attrition of your beta cells and be at risk for diabetes. So it's not 100%. Not everybody gets it, but it's pretty high. Okay,
Norman?
What is there about the disease that causes a circulation problem in legs and feet?
Yeah, that's another very good question. So high blood glucose damages small blood vessels. You see it in the eye. It's called retinopathy, and you see it in small vessels, and it aggravates atherosclerosis, just larger. Atherosclerosis occurs in large vessels. Vessels in the heart are fairly good size, are pretty large. Vessels that go down the legs are pretty good size. But then the high blood glucose damages the smaller vessels. So, and high blood glucose also damages nerves. So if you have nerve damage and you can't feel your feet, you're way more likely to get an injury from doing almost nothing. I mean, a blister or injury from cutting toenails. You know, almost anything can cause an injury. And then if you don't have adequate circulation, sometimes the pulses feel okay. If circulation is impaired, then injuries become infections, and infections don't heal, and it's a progressive problem. So it's complicated. It's more than one thing usually. And not everyone with neuropathy, nerve damage, ever runs into a foot ulcer. My dad is 97. He does not have diabetes, but he does have nerve damage from something else. Presume doesn't have diabetes, but has neuropathy. And he ended up with some ulcers on his feet that have healed. They've healed up. But even non-diabetics can get some of the same things.
I do.
Yeah. Yeah, big risk.
Dr. McGill, I have a question. How often should people replace their glucose meters?
Yeah, the answer is we don't know for sure. Some seem to work for 5 years or so. Others just maybe were never very accurate. Some brands are more accurate than others. You might have to replace batteries in them once a year. I would say 3 to 5 years, probably. And one of the things you can do is, do a quality test on your meter by bringing it in when you go to the doctor. And if they test your blood sugar, do a test on your meter, see how close they are. When people do this, sometimes they're 100 points off. So, we're adjusting medicines and insulin by meters that are 100 points off. That's crazy. So it is, or if they're drawing blood and going to get a glucose, test your blood sugar with your meter when they're doing that, and write it down and say, okay, it was 132 when they drew my blood. What does the blood test show? And nobody ever does these things, but you never find a laboratory or a doctor's office not having any quality assurance. So strips, it can be the strips also. Strips sit around too long or are exposed to air, that kind of thing. So can be either the meter or the strips. Okay, should diabetics see a podiatrist for trimming toenails? So toenails get kind of thick and funny as you get older. It gets harder and harder and harder to reach down and get to your feet and your toes. Medicare pays for podiatry visits every 3 months. It's that 80-20. Supplements sometimes cover the rest. So we have a foot nurse in our diabetes clinic. She's not a podiatrist, but she does this kind of thing. So the answer is more yes than no, but if you're perfectly capable, you have perfectly good sensation, you're perfectly capable of doing it, I'm not sure there's a huge gain. I would say probably 80% of my older type 2s go see a podiatrist. A lot of them, in which I tell them to, or I think is smart to do. You don't want, long nails become a risk for not fitting into shoes properly and crowding and, causing skin damage on the toe next to it, stuff like that. So you don't want long nails. yeah, learning to manage your foot problems is kind of a big deal. All right, so I'm looking at some values. Yeah, so the blood sugar, the 123 blood sugar depends on if it's fasting or not. If that 123 was an hour after you ate, it's a great number. If that's a fasting glucose, you're right there. You're really there. I would check an A1C to see if it's elevated. If we did a glucose tolerance test, meaning that glucola that you drink, and you test the 2 hour, you'd probably have diabetes with that fasting glucose. So I think the 90% chance you already have diabetes, mild. But so TSH is a little bit elevated. I'll tell you what I tell people to do with thyroid numbers like that is if you cook at home, use iodized salt. So take a multivitamin, use iodized salt, and then get it retested. But if you're getting your labs retested that include thyroid labs, you have to stop a multivitamin 3 or 4 days beforehand. There's an interference. So it's good to take. And the reason is that some of this could be just mild iodine deficiency. And we see a lot of it. People have stopped using iodized salt. The other thing is to not take vitamins before you get these labs measured because they interfere. With the lab test, it's an interference at the level of the laboratory. So stop all your vitamins before you get your thyroid rechecked. By good old-fashioned Morton salt, not kosher, not sea salt, not Himalayan salt. And you use sparingly and eat some fish, that kind of thing. Okay. Mother was an insulin-dependent diabetic. Yeah, so the fasting glucose of 123 does not scream insulin dependence to me, but does scream getting closer, already being at mild type 2, non-insulin dependent.
So we have about 5 more minutes. We're going to be wrapping up. Are there any final comments or questions?
Now unmute yourself if you have a question.
Dr. McGill, I do wonder, when people are traveling, are there certain foods that you can recommend that people take with them or have on hand that are good for diabetics to eat while they're away from their homes?
So if you're on insulin, you have to carry something to treat a low blood sugar. And you can't carry liquids through airports. You can take liquids in a car, so juices are fine. You have to have something with you to treat a low blood sugar. You can't rely on, oh, they're going to give me a snack on the plane or something. No. You have to be responsible to treat that. So good old jelly beans, something like that is appropriate for treatment of a possible low blood sugar. That's your responsibility. That, and have I been called on airplanes to help people? Yes, who didn't bring anything with them and took insulin and et cetera, et cetera. So you have to do that. Now, every place you eat, there are choices that are healthier and choices that are less healthy. And I think the thing to do is just simply to get, eat the healthiest option that you can. So instead of a, pizza or, burger and French fries, you might get a hamburger and have a salad, for example, and watch quantities. There are always choices, and people who, seem to think they don't have a choice. The answer is a hamburger and French fries, no matter how many other options there are. And there are all kinds of restaurants in airports, or while you're traveling. You can figure it out on your phone where there's a Panera Bread, for example, instead of a Burger King. Or you can take it with you. So the big thing is to take something to treat a low blood sugar. The other things are to not fall prey to the American fast food culture and just eat because it happens to be convenient. Or take a cooler and, take sandwich stuff, stop at a rest stop and do it that way. Whatever is appropriate for you. It just takes, then if you're taking insulin, you got to match the food and insulin, that sort of thing. It takes a very concerted effort to manage diabetes well, and I applaud all of my patients have put in this enormous amount of effort. But then I wonder about people who just seem to have more excuses than the day is long about, what they can't do. It's like, well, I think you should focus on what you can do and make the best choices you can. Things will go pretty well. Don't take your insulin if you're going to be in a 3-hour plane flight with nothing to eat. And, go see a diabetes educator and get some of those questions answered. Medicare is covering these continuous glucose monitors, which we strongly advise. They've been a huge help. So increasing your monitoring, you have to be on 3 injections of insulin is the problem. They're not approved for everybody. But sometimes if you're going to be, you can buy them over the counter, or you can buy them in self-pay. Some are not too expensive. It would be an option if you're going on a trip and you're concerned. So I would focus on the things you can do, the planning that you can put in place, and not, I assume if you're traveling, it's because you want to travel. Traveling's fun. We're all going to be back at it. So take supplies. I've had type 1 patients leave town, go to Arizona and not have insulin. I've had that happen. After 30 years of diabetes, anybody can make mistakes. So pack your diabetes supplies. It's just very common for people to not have pills, insulin, meters, strips, all of the things they need. So be sure you either make a list or get that stuff packed up. Diabetes is a big hassle. It's a huge, huge hassle in your life. So it doesn't take kindly to a very passive approach. You have to be have a pretty active approach about it. Is that what everyone is experiencing? Just so you know, we know that. We completely know that. But it's also doable. We can manage diabetes pretty well if we put in the effort.
Well, I am mindful of the time, and it's a few minutes past 3. I just want to thank you, Dr. McGill, for being here today and sharing your expertise with us. We know how busy you are. And we appreciate the time that you have spent educating us today.
Oh, thank you. Thank you very much. It's been a pleasure. Good luck to all of you. Thank you.
Thank you again, everyone.
All right. Let's see.